Hi, good morning everybody. We'll get started. Thanks very much for joining us today for our Manchester Genomics Roadshow. Just some general housekeeping really. There is an expectation there's going to be any fire alarm practice today, but obviously if there is an alarm, please make your way to the entrance and outside of the building. Can I ask that everyone turns their phones to silent, please, during the presentations? That would be fantastic. And before we start, I just wanted to ask all members of the GMSA team to make themselves known by raising their hand, just so that everybody, will be available in the marketplace to discuss everything genomics during the break that's due to start at about 10:35. We are recording the event and the stage and the presentations, and that will be shared following the event via our website. And there will be roving microphone available for Q&A if necessary, and that's with my colleague Salima that's sat at the back there. And finally, feedback really helps to inform these events moving forward. This is the third event that we've held, and each one has informed the succeeding one. So we really value your thoughts on the topics that we discussed today. There will be a feedback QR code at the very end of the event, and if you could just take, it is only sort of 3 or 4 simple yes or no questions, and a confirmation of attendance certificate will be available following the event. But again, thank you ever so much for making the effort and coming out and joining us today. And I'm going to hand over now to Professor Bill Newman.
Go that way. Lovely, thank you. Right, lovely. So thanks so much for coming. We'll get rid of that. I'm Bill Newman. I'm a clinical geneticist up the road based at St Mary's. We've been going around to different centres around the northwest. So we've been in Preston, been in Lancaster. We're planning to go to a number of other places just to talk a little bit about what we do in genomics, see how that's relevant to you in your clinical practice, and what sorts of things have been happening and we expect to happen. So the Clinical Genetics Service in Manchester has been going since 1963. So it's not such a new thing, but there's suddenly a lot of interest, and that comes, I suppose, from the NHS, from a lot of politicians starting to think that genetics is important. I mean, we obviously think it is, but they've put it high up on the sort of healthcare agenda, which is good in some ways, has some challenges, but over the last few years there have been some sort of structural changes. And structural changes are never really that interesting, but to give you a little bit of a context of what we're about, is that a number of you were involved with or will have heard of something called the 100,000 Genomes Project. So that started really in about 2013 after the Olympic Games. David Cameron was very keen, because of his own personal experience, to introduce whole genome sequencing. And to use that as a diagnostic test. So his son, Ivan, had a very severe type of inherited epilepsy, and the only way that they got the diagnosis for that was by using this new type of test. And so he felt that that was useful for lots of other people who had children with rare conditions or were affected by rare conditions themselves. But also there was a sense that that new technology might be valuable in giving people information about what the right treatment for certain types of cancer were as well. So the 100,000 Genomes Project sort of delivered a number of genomes. There were new discoveries made. There's still a lot of work going on looking at all of that data and trying to understand, how do we use it best? How do we introduce it in clinical care? And after the project sort of officially finished, there was a sense that the whole sort of genomic system needed a little bit of a restructure. And so that sort of developed into the clinical genetics services, so where I work, where we have genetic counsellors, specialist nurses, dietitians, where we look after patients and families with rare conditions. So they can be conditions that affect children with developmental problems, learning disability, heart problems, kidney problems, etc. Or about 40 to 50% of the families that we see, or the patients we see in our department, are people with risk or affected by inherited forms of cancer. So you'll know of breast and ovarian cancer, inherited types of colorectal and endometrial cancer, and then some rarer types of cancer as well. So we've got the clinical service where patients come to our department, or we go and do clinics around the region and see them, give them advice, do genetic tests, refer them on for appropriate screening or treatment, etc. Allied to the genetics, clinical genetic services, so there's one in Manchester, one in Liverpool, we have a number of genomic laboratories. So there are lots of genetic laboratories around the country, and back in 2018 they were sort of amalgamated within regions. And so the one in Manchester was fused with the one in Liverpool, working very closely with colleagues down here at the Christie, and up in Blackpool, where they do some cancer testing, to try and one of the big problems with genetic testing up until about 3 years ago was that it was really dependent on what you could access where you lived in the country. You'll remember people talking a lot about this postcode lottery. And it's completely unacceptable that if you live in Leeds, or you live in Leicester, or you live in Exeter, that when you go and see your doctor or counsellor, they can say, well, we'd want to do this genetic test, but I'm afraid we can't do it because we don't have the funding, we don't have the lab that can do it. That's all gone. All genetic testing now for cancer and rare diseases is nationally commissioned. So it's paid from a central budget. It doesn't matter where you live. If you meet the clinical criteria, you can access that testing. Now, there are challenges with that. If you saw The Guardian yesterday, you realise that there are delays in that process. There are some teething problems. But fundamentally, it's improving the equity of access to testing. So it will get there, and it will make a significant improvement into what we're able to achieve in terms of diagnosis, but also informing the right treatment approaches. But what the GMSA, the Genomic Medicine Service Alliance, is about is something a little bit different. And you'll all be familiar with these cancer alliances. And the cancer alliances, are, in my understanding, I think, are like what the Genomic Medicine Service Alliance is thinking about how do we do things differently? How do we connect people? How do we make sure that the services that we are delivering are the best we can? That we're thinking about the new ways of doing things, new technologies, new clinical pathways, and then testing them out in a sort of pilot way before they're sort of routinely adopted to see if it works or not. And so the GMSA was started 2 years ago. And I'm the clinical director of that, a number of people in the team. So we've got nurse leads, midwifery leads, we've got a pharmacy lead, we've got a team supporting all the work that we do with Barbara, who just met, who's our comms lead. And so we're putting out a programme of work, which let me just talk through what that is. So we've got a few key things that we're meant to do. One is finish off some of the work around the 100,000 Genomes Project. The 100,000 Genomes Project had lots of successes, but it has only made a diagnosis probably in somewhere between 30 and 40% of individuals who took part. So that's great for those families in lots of ways, provides them with information, helps their clinical teams make the right decisions for them. But that leaves 60, 70% of people who don't have an answer still. And we need to try and improve that diagnostic yield and come back to people with that as new technologies, new ways of looking at the data, new information comes to light, that diagnostic yield will improve. There's a big program around education and training. So Glenda Beeman and Holly O'Day are our education leads. They've got a team and they've been working with colleagues here at the Christie, but a number of centres across the region, also at Clatterbridge as well, to really get a sense of, as health professionals, what do you need to know about genetics? If you're an orthopaedic surgeon or if you're working in accident and emergency, you probably don't need to know that much about genetics. If you're working in a paediatric neurology team, or you're working on a neonatal intensive care unit, or you're working as an oncologist, you need to know quite a bit about genetics. You don't need to know everything. You You don't need to be trained as a geneticist, but you need to know the stuff that you need to help your patients. And so we're trying to provide resources that are helpful for people. We've been running a number of projects, which I'll tell you about in a second, and we've got a real focus, which Manasa here has been leading, on looking at improved equity of access, and I'll touch a little bit about that. And generally, it's trying to improve people's understanding of what genomics is, what it has to offer, and also its limitations. It's not a panacea. It can't provide all the answers, but in some places, it can be useful. So this is clearly, we're based up the road at MFT, but it's really important to recognise that this is a pan-Northwest initiative. So we've got representation across Lancs and South Cumbria, across to Cheshire and Merseyside, and into Greater Manchester, and across a number of healthcare professional groups, and also with patient representatives and educational leads. And just to touch on our Equality and Diversity programme, we focused in on working with the British, Pakistani and Bangladeshi community as our first group, our minority group, where we felt that there were unmet needs and where we needed to improve, their understanding that we are available and that they can engage with us, but two, what it was and what it is that we can offer and what it is that might be useful. And so we've done a lot of work with the British Muslim Heritage Centre, been working with imams, a number of the political leaders, be they councillors, the local MP, and getting out into the community rather than expecting people to come into hospital and engage with us. We've been going to markets, we're going to the cricket, going to mosques, speaking at Friday prayers, and every Friday prayers that I've spoken to, people have come up to me and said, oh, I've had some interaction with genetics, or someone in my family has been to genetics. And so actually there is already some understanding connection with the genetics work that we do, providing information, but there is still a lot of concern. People worry about how we will use their information, or people have had bad experiences where they are told, well, you shouldn't be marrying within your community because that increases your risks of certain conditions. Now, we know that there are some increased risks around certain types of condition, but it's not for us as health professionals to tell people what they should and what they shouldn't be doing. We should provide people with the information so they can make the right informed choices. And so making sure that that dialogue is engaged and appropriate is really helpful. And so we've been working on a project called Genes and Health. And part of the reason we focused on that is because if you look at all of the genomic data that is available in big terms, so genome sequencing that's been done around the world, over 80% of that has been done in white European ancestry people, so in North America, across Europe, down in Australia, etc. About 10% has been done in Eastern Asians, China and Japan, and less than 2% is relevant to the Indian subcontinent. And so when I see a patient in clinic, I can offer them, from the Pakistani or Bangladeshi community, and I can offer them a genetic test. But the problem is when the result comes back and I find a genetic change, often it comes back as something called a variant of uncertain significance. We don't quite know, is it the cause or isn't it? And part of the reason for that is that we don't have enough information from the general healthy population to compare it against, to know, is this something that you just find in people from that part of the world that doesn't really mean anything, or is it really important to their health problems that we're seeing? We also know that people from Pakistan, men, have a threefold increased risk of coronary artery disease. They have a 4 times increased risk of diabetes, and they had a 5 times increased risk of really severe COVID. So when that first wave of COVID happened and people were going into ITU, certain communities were disproportionately affected. Now, not all of that is due to genetics, but we know that genetics has a significant role in that. And when you look at the UK Biobank, so this is a big resource, 500,000 people, 45 to 65 took part. of those 500,000 people, only 2,000 self-reported themselves as having Pakistani origin. Only 600 are self-reported as having Bangladeshi origin. So you can't do any analysis to look at that data to really inform, well, why are people having an increased risk of diabetes or coronary artery disease? And if we just take the data from the white population and just try and extrapolate it, it's wrong. And what we will do is give people false risks. So we'll say that they're at higher risk than they are, or they're at lower risk than they are, and that's just not acceptable. So we have to do these studies in populations that will, one, benefit from it, but two, where there is that lack of information already. So there are a number of national projects. I won't go through all these in details, but I'll just pick out a couple of them. One relates to DPYD, which, as you'll know, is a genetic test that we now use for the last 2 to 3 years before patients go onto fluoropyrimidine treatment. So these are patients with colorectal cancer or breast cancer predominantly, can be other types. But if you are deficient in this particular enzyme or have genetic changes, you are prone to having severe toxicity when you're given that medication. So now we can do a test that will not predict all of those side effects, but will, in a proportion of people, predict whether they should have a different dose or a completely different drug. And part of our project was to make sure that that was being adopted into routine clinical practice at every hospital across the country where that medication was being used. We've got Jim Hill, who's our colleague, and Marie Kerwin. So Marie's a nurse lead, Jim's colorectal surgeon, who focused a lot on Lynch syndrome. So Lynch syndrome is a condition where you have a higher risk of endometrial cancer and colorectal cancer, as you'll know, and there are pathways in place to try to identify, well, which patients with colorectal cancer is that the cause and what should be happening. There are certain things that need to happen in the pathology lab, certain things that have to happen in the genetics laboratory, and then when you identify people, you need to make sure they get the right screening and their family members get the right screening. And so that's been known about for quite a while, but part of the problem has been that it hasn't really been adopted into routine clinical practice, so we've needed to embed that. And a project that I'm working on with colleagues is around sudden cardiac death. So when a very young person dies in a family, so we had a situation just a couple of weeks ago, a 19-year-old healthy man just suddenly collapsed and died, done genetic testing in him, have identified a genetic explanation for that, which we hope will obviously not change that terrible, tragic situation, but will hopefully help us to put in place appropriate management and care for other people in the family. We've known how to do that for a long time. What we haven't had are the relationships with the coroners to make sure that whenever that situation happens, those families don't fall through the grid. And then we've been focusing on some regional projects, things that we think are particularly important in the Northwest that we can focus on, where we might be able to help colleagues around the country. So looking at the genomic services for looked after children. So lots of children who are looked after, they may have, they have very often very little knowledge about their biological family, whether there's any history of any health problems that they need to know about when they come to think of having children themselves, what that information may be, making sure that we're linked into social workers so that people can access the relevant information. And then a project that our colleague Naz Khan has been leading on, particularly in Burnley and Blackburn, where we know that families with breast cancer particularly, but also with bowel cancer, particularly in the Pakistani community, aren't coming forward to get information about what that means for other family members. So we've got really good engagement with Pakistani families when they are concerned about their children because their child has a health problem, and they'll come and discuss with us what that means. but for themselves, if they're older and they have breast cancer or bowel cancer, they won't come forward. And there are clearly some barriers and concerns why that is, and we need to overcome those. So the final thing I'm going to talk about is just an example of a project where we've been trying to capture a new way of thinking about how we do stuff. So, and it's not so much about discovery, it's about taking information that we already know about and using that and bringing it into real clinical application. So for the last 30 years, it's been known that 1 in 500 people carry a change in their genes, which means that if they're given an antibiotic called gentamicin, that they'll go deaf. And that's particularly true of newborn babies. So if you are in a situation where you have a child that's born with a condition like cystic fibrosis, you know at some point in their life they will need gentamicin, so you can do a genetic test, the results come back 3 days, 5 days later, and then you know whether you can give that drug or not. But if you have a situation with a newborn baby's born, needs to go to the intensive care baby unit, to SCBU, you need to give them that antibiotic within an hour. So waiting 3 or 4 days for a genetic test through our laboratory just doesn't work. So for the last 30 years, we've known this information, but we've not been able to do anything about it. So approximately 200 babies every year in the UK go deaf because they're given this antibiotic, and you could potentially avoid that. So what we did was we worked with a small biotech company called GeneDrive in Manchester to develop a test where you do a cheek swab from the baby when they're born, and then you pop that into a machine, and then you get a result after about 25 minutes. That's done by the neonatal nurse just at the baby's bedside. Now, that all sounds great, but what we needed to do was show that it actually worked in practice. There's one thing doing something in the lab and something doing it on the ward, when in the middle of the night, where everyone's rushing around, it's really busy, you've got a sick baby. And so what we wanted to see was that doing this test, number one, didn't delay introducing that, giving the baby the antibiotics. And we found that there was no difference at the beginning, before we introduced the test, and after the test was used. We showed that the test was very sensitive and specific, and just in the study period, we showed that there were 3 babies that had the genetic variant that we gave a different antibiotic to, and they didn't go deaf. And so that's now been rolled out in Manchester. It's routinely used at St Mary's. We're planning to roll it out into North Manchester, to Wythenshawe, other hospitals around the Northwest. And NICE gave approval for this a couple of weeks ago to look to roll this out across the whole country. And part of the reason for that is because you think, gosh, this sounds expensive, it's a fancy new test, it must cost a lot of money. Well, it does cost something, but if you think about the savings that, one, in terms of the emotional, psychological impact on that family of having a child with a hearing deficit, but also the actual monetary cost of cochlear implants, which cost £60,000, £70,000 a time, that actually it's a very strong economic case that introducing this test for all relevant babies on NICU saves the NHS probably about £5 or £7 million every year. So I think that's just an example of where you can take an old bit of knowledge and try and think, how can you impact upon a clinical pathway to do something different? And they're the sorts of things that we're really keen to do with the GMSA. And part of that is going and having days like this where we speak to colleagues who are at the coalface and have challenges and want to think, well, could we do this differently? How can we do it better? It's not to say we'll have all the answers, but at least we can give it a go. So thank you very much. I'm happy to answer any questions quickly if you want to. I'll be around and about, but if not, I'll introduce you to John, if that's okay. Any questions? No? You can have a think and then catch me later. All right. So it's my absolute pleasure to introduce you to John McDermott. John's an NIHR clinical fellow who's been working with us for a number of years. And John's really been driving forward a program around pharmacogenetics with me and a number of other colleagues in the team.
you very much. Thanks very much. So, as Bill said, our work focuses around pharmacogenetics, so how we can use genetic variation to improve the safety and effectiveness of medicines. So we know genetic variation is common in the population. We all have around 4 million differences compared to the so-called reference genome. The question is, how do we take knowledge of that genetic variation and apply it in practice to improve medicine safety and inform personalised medicine? And our group have split that process up into a number of relatively artificial steps. The first is establishing that genotype to phenotype relationship. How does a genetic change influence the safety of a medicine? Once you've established that, you need to have a system by which you can test for that in routine clinical practice. And that might be around developing new novel point-of-care devices, as Bill's just spoken about, or developing informatics solutions to ensure that data is available to clinicians at the right time. And then once you've done that, you need to actually put it into practice to show it isn't disrupting normal prescribing behaviour or normal practice generally. And then embedded within that, you need to have work with patients and the public to ensure that this type of approach is acceptable. And also we work with health economists to ensure that what you're developing, the approaches you're developing, make sense in the NHS landscape. Now, what we've been very good at for a number of decades in genetics is establishing that genotype to phenotype relationship. And what increasingly we're looking around, especially within the GMSA, is this side of the translational spectrum. So pharmacogenetics is the study of variation in DNA sequence as related to drug response. It's also referred to as pharmacogenomics. So knowledge of genetic variation and using that to inform medicine selection. The idea that people respond differently to different compounds is not a new one. It's a frequent and frustrating clinical phenomena that we're aware of, that people respond differently to medicines, but arguably is one of the oldest observations in medicine. This is a 16th century French folio drawing of Pythagoras, and he's shielding away from a fava bush. And Pythagoras and the Pythagorean Brotherhood weren't allowed to go near, touch, eat fava beans. And the reason for that is because Pythagoras, it said, saw someone eat a meal containing fava beans. The next day they got incredibly unwell and died. So he and the Brotherhood said, well, they must contain evil spirits. So that idea that fava beans are somehow evil has permeated throughout history. The priests of Jupiter in Rome similarly weren't allowed to go near fava beans, and to this day festivals around the world contain beans. So this is the Setsubun festival in Japan, where beans are thrown to ward off evil spirits. And it may well be apocryphal, but it's interesting to consider that what Pythagoras actually observed was an individual with G6PD deficiency, and this is a relatively common X-linked disorder, and these individuals, if they have a reduced enzyme activity of G6PD, that in red blood cells can cause an increased production of these free radical species under oxidative stress. And so that oxidative stress can be caused by certain compounds, like fava beans, and certain types of medicine. And it leads to hemolysis and the individual getting very unwell. So our work is to try, in very simple terms, you want to give a medicine to someone and you want them to have an appropriate response to that medicine and no adverse drug reactions. We know sometimes you give a medicine to someone and they have an adverse drug reaction. Sometimes you give a medicine to someone and they have a poor response. But very simply, what we are trying to do is increase the number of people in that middle group and decrease the number of people in the group on either side. And on an individual and a societal level, that has major implications for health outcomes. It's obviously good for the patient, but it could save a huge amount of money for the NHS. So we know that poor medicine's effectiveness and adverse drug reactions are common and costly phenomena. It's related to a number of factors: poor medicine's adherence, suboptimal dosing strategies. So genetics isn't everything, it's not a panacea, but we know that predisposing genetic variation also plays a role. Many medicines need to be metabolized by enzymes in the body before they can have their desired effect, but common genetic variation can influence the activity of those enzymes. And if you have reduced activity or changed activity of those enzymes, you can potentially have reduced levels of active metabolite or build-up of potentially toxic species. And this variation is common in the population. in the patients we see in the genetics department, we see patients with rare disease, so rare disease, cancer predisposition syndromes, relatively rare disorders. We know from large biobank studies, such as the UK Biobank, that around 99% of us, pretty much all of us, carry genetic variation which would influence the response to a certain medicine. Despite extensive evidence for multiple gene-drug pairs, there remains a translational gap. So there's a group called the Clinical Pharmacogenetics Implementation Consortium, and there's a European counterpart called the Dutch Pharmacogenetic Working Group. And they compile evidence. You can think of them a little bit like NICE. They synthesize the evidence in the literature and create guidance for pharmacogenetic prescribing. And there's 440 gene-drug pairs with any prescribing evidence, and 26 of those have the highest level of evidence where explicit pharmacogenetic guidance has been developed. However, in the United Kingdom, only 4 of those gene-drug pairs have reached clinical practice, and that is tested for in a relatively reactive strategy. So clearly, there's a translational gap, and that's what our group, our team within the GMSA, have been looking at. How do we develop strategies to improve the uptake and delivery of pharmacogenetic testing? So that's what we've been looking to do. So when you think about how you can deliver pharmacogenetics in clinical practice, there's 3 broad models. So the first is what we're doing at the moment. It's a reactive testing strategy. You see a patient in clinic, you take a blood test or a saliva test, and you would send that to a laboratory, and you're testing for a single gene-drug pair. And we do that for DPYD, MTRNR1, TPMT, and to an extent, HLA, but there's geographical variation around that. And you can assess how useful that is using quite traditional outcome measures. Increasingly, around the world, and what we're exploring, are these other 2 approaches. So reactive with planned reuse, so that's still a patient presents to you, but rather than doing a single gene-drug pair test, testing for a single gene, you would do a panel-based test, where you test for a large number of genetic changes at that point in time, and then integrate those data within a patient record so they can be used in the future. And fully preemptive is where you don't wait for that trigger, you just decide you're going to do that at a set point in someone's life, and then that can be used to inform all their prescriptions moving forward. Now, these outcomes are more challenging to assess, both from a kind of traditional outcome perspective, but also from a health economic perspective, because the journeys that patient can go on are incredibly varied and incredibly heterogeneous. But our team are looking at how we can potentially do that at the moment. And as Bill said, point of care testing is an alternative approach. Now, our group have been asked to understand how we can deliver this in practice. And when I used to give talks like this, I used to have loads of slides going through the evidence base for pharmacogenetics and in the different use cases for pharmacogenetics. We don't need to do that as much anymore because about a month ago, the PREPARE trial was published, and that was a randomized control trial looking at panel-based pharmacogenetic testing. It's published in The Lancet, and it demonstrated that panel-based pharmacogenetic testing can reduce the rates of adverse drug events by 30%. And as a single intervention, that is a phenomenal outcome. So the value of this has been proven for some time, but this has really weighted the evidence towards implementation. So think about preemptive pharmacogenetic testing. It offers an alternative solution, and it bypasses that standard turnaround testing paradigm. So at the moment, a patient presents to you, you think they need a pharmacogenetic test, but you're waiting weeks or months for that test to return to you. So you get the results, and then you can issue a prescription. Now that might work in some clinical scenarios, but it's clearly not going to work in the bulk of clinical scenarios, especially where there's an element of time pressure. Preemptive testing, or reactive testing to an extent, allows us, a reactive planned reuse, allows us to bypass that turnaround time paradigm. You have the results available, they're embedded within the record, and then you can use them to inform prescription moving forward. And so that's what our team have been exploring. So we were asked to think about how we could design a panel-based pharmacogenetic testing strategy. And rather than starting from the beginning, we recognise this is already being done around the world. The Netherlands and the US are very much leading on this, and it is embedded within their healthcare service. So we undertook a systematic scoping review, and we identified preemptive pharmacogenetic or panel-based pharmacogenetic programs around the world. So there's a relatively large amount. We identified 104 manuscripts, 40 distinct programs. The vast majority were in high-income countries, and 2/3 were in the US, where, as I've mentioned, the bulk of this work has taken place. And there is a reason for this, which is important, and I'll come to that. So we undertook interviews with the leaders of all these centres, we assessed the literature thematically, and we used something called the Consolidated Framework for Implementation Research, which is a flexible implementation framework that allows you to synthesise literature that is relatively heterogeneous. So it's split across multiple domains, and within those domains you have a number of constructs. So this is the characteristics of the intervention domain, and you've got things like cost, the design, complexity of the implementation, and we were able to understand whether they were described as a barrier or a facilitator. I'm not going to go through all these in detail, but what I do want to highlight, which is critical to our implementation challenge, is this concept of the outer setting. So the outer setting refers to when you have a new service or an implementation at your institute, so say the Christie, how does that then interact with the wider healthcare ecosystem? So that's critical in the NHS. You can't have one implementation program for pharmacogenetics at MFT, but say, well, we're fine, we don't need to worry about wherever that patient might go in the healthcare system more generally. It has to be connected. That's not as much a problem in the US, where you have a healthcare institution who all use the same electronic healthcare record, and they don't tend to move around as much as patients do here. And so that's reflected in the literature, where the outer setting was barely touched upon, which is going to be an issue in the NHS. So we drew up a number of key considerations for designing a pharmacogenetic service, but as I've said, there's very little mention of the outer setting. And this helped inform the Progress programme, which is a package of work looking at delivery of a pharmacogenetic programme for the NHS. Split across 3 work packages, so we've got development and validation of a pharmacogenetic panel, so choosing the technology. Work package 2 is developing an informatics solution to support pharmacogenetic guided prescribing. And work package 3 is implementation in practice. And as previously, we're working with health economists, implementation scientists, and patients to understand the value of this. So with regard to the test itself, we looked at the assays that were available on the market, and we tested this within our genomic laboratory hub. So we validated a series of assays against gold standard samples, and we were interested in standard performance metrics, so things like sensitivity, specificity, but we were particularly interested in other attributes of the test: the cost, the turnaround time, the throughput. Because for pharmacogenetic testing, you need to have relatively high throughput, it needs to be cost effective, and you need to be able to demonstrate that it's not going to be hugely burdensome. Because compared to rare disease, this is going to be relatively high throughput and low complexity, compared to rare disease where we have somewhat low throughput but quite high complexity. So we came to a final panel choice, which was the Agena Veridose core system plus another system for copy number variation. What I want to highlight to you guys is that the turnaround time here is a day, and the cost per genetic test is £20 per sample for the reagent costs. So as a mechanism for delivering genetic testing, this is relatively cheap, relatively quick compared to standard testing technologies. So we have a test that can deliver pharmacogenetic variation, or test pharmacogenetic variation in a clinically relevant time frame, and it's cost effective. But the question is, how do we make that data available to clinicians in a meaningful format? So this is what, let's take for example a patient being prescribed clopidogrel somewhere in the healthcare system. We know that variation in the CYP2C19 gene can impact the effectiveness and safety of that medicine. This is what the data looks like coming out of the system, meaningless to the vast majority of clinicians. So we need to find a way to get that into a format that means something to clinical staff who are going to be looking at that data. And the nomenclature we use in pharmacogenetics is somewhat different to other types of genomic reporting. So there is a process to move these data through into something called a star allele format, into a metabolizer state, and then to give actionable prescribing guidance. And so we've developed a piece of software that plugs in to this what's called CPIC API, so that's the Clinical Pharmacogenetics Implementation Consortium. So those 26 guidelines that I talked to you about before, we've developed a mechanism to pull in the guidance from those documents and automatically move those data through from genotype through to this guidance. So the bioinformatic hands-on time is basically 0 compared to rare disease and cancer diagnostics, because we have these rules in place and we're dealing with very binary results. We're not doing testing where you're going to get variants of uncertain significance, certainly not at the moment. So we can take this approach. So we have a technology, we have a system by which we can convert that into something that's meaningful, but they're both tractable problems. That's what we do. It's kind of our bread and butter in the GLH. The question is, how do we get that data that sits on a server in our laboratory out into the hands of clinicians around the healthcare system who are using diverse and disparate electronic healthcare records, so EPIC, EMIS, System 1. They don't talk to each other, they don't want to talk to each other, so how do we do that? And the approach we've taken is to develop something called a clinical data repository, or pharmacogenetics as a service. And so the idea is we move the data from our servers and store them within a cloud-based repository using a data standard. So OpenEHR and message using HL7 Fire. And once you have it stored in that open format, then you can work with different clinical decision support providers to move those data out in a relatively agnostic way. So as part of the progress study, which I'm going to come on to in 1 second, we have a phased approach. Phase 1 is we've developed a kind of front door to our clinical data repository that clinicians can interact with. But phase 2, which is where we want to get to, is just pushing those data out into each electronic healthcare record system. We don't want people to have to access another system. So this kind of front door, we've piggybacked on a system called Geno, which is linked to the NHS spine. So you search for your patient's NHS number, and these are all fake patients. And so this patient has been enrolled in the progress study because they prescribed citalopram. And so the system knows that citalopram effectiveness is based on CYP2C19 variation, and it's presented. So you do have the results, but you have the clear guidance here. And we've co-designed this with pharmacists, with GPs, with patients to understand how they want to see this type of information. And then you can search for lots of different medicines as well. So for us, what's particularly important is this agnostic end-to-end process. So by using open data standards, and we're working with the Global Alliance for Genomics in Health, who kind of police data standards in genomics, it allows us to be agnostic of genotyping platform and agnostic of EHR provider. If we took a somewhat traditional approach and said, okay, we're going to work with genotyping company A and we're going to work with EHR provider B, then that's fine, providing the lab always uses genotyping platform A and your clinical setting always uses that EHR system, but that's not how the NHS works. So this approach is hopefully flexible and scalable across the country, which is what the GNSA is trying to do. So very briefly, work package 3 is around implementation. So we've developed an implementation trial to test that kind of last part of the process. Can we deliver pharmacogenetic testing without it disrupting normal clinical practice as part of routine care? So phase 1 begins at the end of this month, and we've chosen 5 GP practices across the northwest of England. We're going to give them this system, GPAS and Geno, and then eventually we'll give them the system where the data is pushed out into their EHR. But what we're looking at is individuals who present for a prescription of a new medicine, antidepressant, statin, or a PPI, and we're undertaking this under research ethics. And we are interested in these kind of process outcomes during phase 1. So the utilisation of the data. Can we deliver the data within a 5 to 7 day turnaround time? Is it being used to modify prescribing behaviour and the spread of the genetic variation? And then phase 2, over the next 18 months, we're looking at expanding recruitment geography, and the approach we've taken with that agnostic solution will hopefully allow us to do that with having to do individual integrations across each site We're looking at more patient-focused outcomes for clinical utility and specifically working with secure data environments to try and pull that data on a longitudinal population level. And then critically, we're looking at integrating with other EHR providers. So we recognise we're doing this in primary care at the moment, but we will be doing it in secondary care and community pharmacy as well. And then the idea is that this will move towards a clinical rollout of pharmacogenetic testing. So the actual process for recruiting patients is incredibly complex, as you can see here, and that's because patients in the real world are complex. They attend their GPs in a different way. Some want virtual appointments, some want remote appointments. But ultimately, we've created flexibility in our protocol, which was approved a few weeks ago. So that index prescription, you've got the option to issue or delay it. You can have saliva testing, you can have blood testing, recruitment can be remote or face-to-face, and we're testing twice weekly in the laboratory. We've got different ways that we're returning the data. One of the things we definitely need to think about is once these data are returned, what happens if the clinician doesn't know what to do with that information? And so we're working with the specialist pharmacy service who can provide advice, so working with existing solutions. And as I've said, we're going to be working with secure data environments to monitor longitudinal outcomes for pharmacogenetics, which is really important. And as I said, we're opening for recruitment later this month before expanding across other regions. So I'll leave that there. The GMSA has provided a structure by which we can hopefully begin to deliver pharmacogenetics in clinical practice. If we can achieve that, the outcomes are potentially really exciting, saving money for the NHS, but also improving patient outcomes. Thanks very much. And I'm happy to take any questions, or I'll be around at the break. Bill enjoyed my presentation so much he's run away, so I don't know who's...
How easy was it to find GP practices that were interested in the project, and how easy do you think recruitment will be?
So the first question, it was remarkably easy. GP practices were incredibly enthusiastic about taking part, and so we had to draw the line at 5 because we wanted to check it worked, but we probably have a list of around 20, 25 practices now who have said that they are interested in taking part, and that number is increasing. So there's a real enthusiasm about delivering this, and people are excited to be part of this new intervention. With regard to recruitment, we hope that it will be. The reason we've designed it with so much flexibility is to not... We don't want to create an intervention that just puts more work on the GP. So we've tried to create something that takes that the need for recruitment off the GP and moves it onto the research team. We'll find out in a month, but we're hoping that the way we've designed it, it should be relatively straightforward to recruit people. And that virtual recruitment approach should hopefully make it quite easy. Fingers crossed.
Hi, how do you think you can integrate this into developing clinical trials for new drugs, or is that happening? What percentage of clinical trials incorporate genomic testing?
Yeah, I think that is happening at the moment. So this type of testing is incredibly cheap to do. As I said, it's £20 for kind of a relatively good pharmacogenetic test. And so what a lot of pharma companies are doing alongside a lot of their protocols, they're doing pharmacogenetic testing of their patients, and then that allows for subgroup analysis. So I think this will become part of routine practice, and I think for or routine clinical trial development, and I think to a great extent it is done quite a lot at the moment. Yeah, and I think it makes complete sense. So if you find that individuals who are poor intermediate metabolizers for a certain P450 enzyme have worse outcomes or better outcomes, that's an interesting thing to know. And companies have recognized that it allows them to potentially identify cohorts where it's going to be most valuable for.
Okay, everybody. Thanks, John.
Thanks.
Thank you. Hi, everyone. I'm the last session before the break, so I won't keep you long. So I'm going to talk today about one of these transformation projects Bill earlier in his talk mentioned about multiple transformation projects that are happening within the GMSAs. I myself am part of the GLH. I'm a scientist in the cancer team, but we're working closely on this ctDNA project that we'll go through now. So traditionally, when we do testing for cancer patients, we are testing the tumor tissue. That's the gold standard. So if we want to look for somatic, acquired genetic changes that's going to impact treatment, we usually receive a tissue from the tumor from the patient. We look for these somatic changes and we report them back to the referring oncologist and pathologist and so on. It has been amazing, and we still, it is our main pathway for testing, but it comes with a lot of challenges as well, and I'm sure a lot of you will be aware of it here. First of all, to get the biopsy, that's invasive and that's risky, and sometimes patients are unwell and are unable to undergo this. When we receive the sample, sometimes there isn't enough tumor material in the sample, so most of the sample can be normal tissue. Or the tissue quality is not great. Now, formalin fixation is amazing. It preserves the tissue structure, but when we try to break that down in order to get the DNA or RNA out, it comes out in a really bad quality. So we develop technologies to deal with that, but it's still not ideal. And also, tumors are heterogeneous. So when you take a biopsy that can represent part of the tumor, it may not represent the whole tumor. And because tumor samples have to go through pathology labs, have to get fixed, have to be examined by a pathologist, that does add to the process. It takes longer. So there are challenges around pathway optimization and around the turnaround time. And also, if you want to monitor the patient's response to treatment, you want to see if they are recurring and so on. Serial sampling is not possible when you have to keep on taking a biopsy. And that's why we're looking at circulating tumor DNA. Now, if you don't know what circulating tumor DNA is, basically when normal cells break down, they release DNA into the bloodstream. So if you take a blood sample from someone and you get rid of all the cells that we usually get the DNA from, you will find what we refer to as circulating free DNA. That's DNA in the blood that's not bound to any cells. Now, if the patient has cancer, the tumor cells also break down through apoptosis, through necrosis, and they also release their tumor DNA into the bloodstream. And that's what we refer to as circulating tumor DNA. Now, there has been some tests that we use in routine practice for circulating tumor DNA, and they have been successful because, and sometimes referred to as liquid biopsy, can really add value where we are struggling with the tumor, as we mentioned earlier. So, for example, some patients, the samples are insufficient. They have been used for other routine tests, and there is no pathology sample left to be sent for us to test. Or sometimes it is unsuitable. The quality of the DNA we can't analyze. We try to analyze, but the testing keeps on failing. Or there are patients where biopsies are not available in the first place. Or sometimes when we test using the liquid biopsy or the circulating tumor DNA, we're actually identifying things that we have failed to identify in the tumor material because of the tumor heterogeneity issue. And because it's relatively non-invasive, you're just taking a blood sample and sending it to the lab, it comes with a lower cost, and it is easier to collect and send over, and it is also relatively cheaper. And because they are non-invasive, you can take multiple blood samples, so you can monitor a patient through, for example, treatment in order to see how well they're responding, and you can do serial sampling throughout the patient journey. So it's really adding good value to the cancer patient treatment pathway. However, it comes with its own limitations. So, for example, because normal cells also release DNA into the bloodstream, the fraction of the circulating tumor DNA can be very low. And because of that, we really need highly sensitive technologies in order to look for a mutation that might be present in the circulating tumor DNA and find that out of the higher concentration of circulating free DNA coming from normal cells. So really highly sensitive technologies are needed. And also, not all patients will have circulating tumor DNA, or the level of circulating tumor DNA can vary. So sometimes you're doing sampling from patients and the level is very low, and sometimes the level is high, and that comes with the risk of false negative. So if you don't identify something when you're testing a liquid biopsy, that doesn't mean it's not there. It may mean that you're not testing circulating tumor DNA in the first place. And that's why it is still not a diagnostic test. And although the samples are easier to handle than pathology samples and the pathway is simpler, they are also a sensitive sample. So if you take a sample to send to a genomics lab in order to look for circulating tumor DNA, you need to do that relatively fast, and you need to deal with the sample in a certain way, because if you take the sample and it's stored incorrectly or it takes time in transport, what happens is the normal cells, the normal white blood cells in the blood sample will break down, and it will flood it with more and more of circulating free DNA. Circulating tumor DNA ratio will become smaller, and we will not be able to detect these mutations. And that's why really this project is happening in the GMSA in order to evaluate, can we introduce such service at a bigger level in the NHS. Just put this slide to highlight actually something that's really not possible with pathology tissue. This is the reference here if you're interested in it, but basically this paper has shown how often you can sample a patient in order to study the progress of their tumor and monitor any clonal evolution in the tumor, any change, any, for example, acquisition of resistance mutations. So really, other than helping with complementing the shortcomings that can be a problem because of pathology sample, it is adding a new angle that was not possible when you're only depending on invasive biopsies. So the scope of this project is basically to evaluate this process through recruiting 700 patients. So Bill mentioned earlier that there are 7 GLHs. This is 100 patients per GLH. And we're targeting patients with lung cancer, specifically stage 3, radiological evidence of stage 3 and 4. And we are testing them. We're going to a private provider, but we're testing them using a test directory gene panel. And the idea behind the project is basically to evaluate guidelines and an end-to-end pathway that can be used in order to test these patients. So it's evaluating everything in the process to make sure that's working in real life. So it's evaluating packing and sending these samples through to the GLH, identifying the appropriate patients to test in the first place, when to test the patient, when in the pathway it's appropriate to test the patient, and also training the clinicians and anyone who's going to see the patient on how to interpret, understand these reports, and return the results back to their patients. This is the actual pathway, and this is just basically shows. So this is a standard diagnostic procedure for patient, and the transformation project is looking at the pathway for the liquid biopsy and the ctDNA testing running alongside it. Like we said, this is not to replace tissue testing. This is to evaluate what happens if we run ctDNA testing alongside the standard of care tissue pathway. So, and the project will be looking to identify outcomes at multiple levels. So they're looking at to identify the quality of the testing. So what would be the sensitivity, the specificity, and the limit of the detection for these tests? What would be the turnaround time? So the aim is to get these results back to the patients, ideally in 7 days, up to 10 days. And then also evaluate the outcome of testing. Are we detecting enough genetic variants or mutations in these patients? And are they relevant enough? Are they actionable? Are they changing the treatment of the patient? Are they having a true clinical impact on these patients? And also importantly, and John mentioned that in his excellent talk, talking about health economics. Is this cost effective? Is it going to make a positive impact and reduce the costs for these patients? These are the recruiting sites for this project. So there are sites from Greater Manchester, Cheshire, and also Lancashire and South Cumbria. And the testing provider is Guardant. Once the results come back, we have an established genomics tumor advisory board that happens every 2 weeks. This is mainly focused on whole genome sequencing for cancer patients, and basically we discuss patients' results and with the referring clinicians, with other interested clinicians and scientists, and we make decisions on many variants. So the results from this project will also be discussed alongside the whole genome sequencing results in order to help bring that into a pathway that is already established. So far we've tested 25 patients from the region, and the aim will be to finish once we get to 100. And there has been some excellent results for these patients. So this is from one of the patients where an actionable EGFR change was identified, and there has been some mutations or changes that also been identified that would have not been usually identified through the standard testing pathway. Now, the whole data from the project, so we talked about this happening across all of the GMSAs, so the whole data from the 700 patients will be collected, demographics, history, clinical details, etc., and the ctDNA findings, so the variants that were identified and whether they were actionable or not, and then the impact and the outcome for the patients. So have they actually made a difference for them? Then there will be a full analysis that's led by the North Thames and North East and Yorkshire GMSAs, and they basically will integrate that alongside the health economics to see if we can eventually introduce this as a nationally commissioned routine service for lung patients. After that, there will be the discussion around can we expand that to other tumor types. Of course, if it's deemed to be successful for lung patients, then can we go to other tumor types and see if we can replicate that? And I'm sure a lot of you have seen in the news about this test that's been now rolled out in the Royal Marsden and across other areas, which is helping patients avoid unnecessary chemotherapy. So hopefully there are more and more to come from ctDNA testing, and that project will definitely help into integrating that into the NHS services. And that's the end of my talk. Thank you very much. Are there any questions?
Thanks, George. Just to follow up on that point, and to bring to attention also that there is in the early stage 1 lung cancer setting, there is a study that is going on currently in Manchester with radiology looking at X-ray images and embedding AI approaches to that as well as a screening tool to pick up early stage lung cancers as well. Now that still leaves a significant proportion of patients who are not identified through that process and could potentially be approached with, if there's an added ctDNA, how robust does that process become in terms of early identification of those patients? I think that's something, and I can kind of point you in the direction of who the leads are on that study. The challenges there obviously are in early stage lung cancer. The shedding of ctDNA might not be high, but there is literature coming out that suggests that can be done as well.
Yeah.
So that might be something worth considering.
No, thank you. That's really helpful, Anshuman. Catherine?
I was going to ask. Thank you. With the risk of the circulating tumour DNA being so low, how could you confidently rule out the need for chemo?
In this, well, that's why the study is just starting. So it basically, there has been some, so this is to replicate a study that was done elsewhere, where there has been enough findings to show that they were able to identify changes in ctDNA that helped many patients avoid chemotherapy. The test is now being evaluated in the NHS, starting in the Marsden, and will be rolled out to see can this happen, can this be replicated in the UK. So a smaller study has shown that, and now it needs to be evaluated at on a bigger scale.
George, really great talk, thank you. I was interested to know, obviously you're relying on highly sensitive technology to pick up low-level variants in these circulating tumour elements. How much blood collection is actually required? Is it a lot of blood that's needed to generate your DNA extract?
No, we take a standard. There are specific blood tubes that we send out, but a few mLs of blood are all what we need in order to get the plasma out and get the ctDNA. I think one of the important things is sending the sample within the appropriate time frame, and the information is on our website on how quickly you better send the sample and how well to store it or not. The conditions, so for example, not refrigerating and not freezing, but the issue is with some patients, they have plenty of ctDNA in their blood, and that's easy to find, but for some patient, it's very little, and even if you take more and more blood, you're not going to enrich that much more, so it's a standard amount of blood sample.
Thank you.
Do we know what determines in individuals the level of tumour DNA that's shed into the blood? I mean, if you say some people have got loads and some haven't, what are the factors there?
So, for example, the stage of the tumour, if they've had any specific treatments, and how well they're doing. So there's a variety, and there's also the anatomical location of tumors. So we know some tumour types release more circulating tumour DNA than other tumour types. So it varies between the patients based on the tumour type and also the stage of the tumour itself.
My question, do you predict that you have got a difference between non-small cell and small cell, for instance, or the tumour type, does it play an important part of how much is being shed?
So the tumour type can play a role. There are studies around the level of the circulating tumour DNA and, for example, predictions that can bring into the patient prognosis. We don't do that, so we don't test for the levels of the circulating tumour DNA. We look for specific genetic changes and if they're found or not found. Now, for some patients, for example, some lung patients who have had tissue testing to start with, and we identified, say, a sensitizing EGFR change that's allowed them to go on tyrosine kinase inhibitors, then they develop resistance. We then have sometimes a quality control here because we know they have a certain mutation. And if we identify that mutation, then we know that there is circulating tumor DNA. Then we can apply a more sensitive technology to see if they have acquired a resistance mutation. But if you're missing that first primary mutation in the first place, you know that you're not necessarily testing circulating tumor DNA. But we don't quantify the levels of circulating tumor DNA, although that is done in research at the moment.
Brilliant, thank you. I can see the future.
Excellent.
Going into patients' homes, taking a blood test for circulating tumour DNA.
Yes.
Very excited, thank you.
Thank you.
One final question here, please,
My question is about the technologies that are being used to detect these variants, and whether there's any variation in the sensitivity and specificity of each, whether each GLH uses a different technology for testing, or is it just the same technology across the GLHs?
So that's why there was this external provider providing the same technology at this stage. There was supposed to be 2 providers to start with, but then it's going with this provider. But then when we look at adopting it into the NHS as a standard test, then that will be one of the issues that, there will be difference in technologies between different GLHs, but as they get evaluated, each GLH will know its own limits of detection, and there will be minimal requirements to provide such service.
Thank you very much.
Thank you.